Thank you very much for joining us today for our session on From Reactive to Proactive, so some approaches to prevention and self-care. So first, just a little bit of housekeeping. So we are recording the session today. Your videos and microphones have been turned off just while we go through the presentation. But please, if you do have any questions during the session, please pop them in the chat. And we are also going to have a Q&A section at the end. So if you've got anything that you'd like to ask during the session, please pop them in. A note just to say, if you haven't registered for this session directly, so if you joined via a link that somebody else has shared, please make sure that we've got your email address and your job title in the chat, just so that we can make sure you get all the resources after the session. We'll make sure that you get an invite to the D&T network, because that's where you'll be able to access all the resources. And today, the presenters are myself, Claire Temple from Redmore Health, and I'm joined today by Dr. Tom Micklewright, who has many titles, but is also Medical Director at Orca. So again, today's session is brought to you by the D&T Network. So if you don't know, the D&T Network came to life in September 2024 with an aim to connect everyone across healthcare that's interested or involved in digital and transformation. We've currently got around 1,300 members from all different roles across primary care. If you're not part of the network yet, you can scan the QR code below, but after today's session, you'll also receive an invite to join. So the agenda for today's session, we're going to look through a few bits today. So we're going to look through why prevention and self-management matters right now. We're then going to look at identifying those high impact prevention cohorts, and then beyond the highest risk and looking at targeting the activation potential. We're going to look at supporting self-care and self-management at scale. And then we're going to look at what digital support as part of a balanced prevention strategy can do. And we're also going to be looking through the Orca CareNav tool. And then, like I said, we're going to have a section at the end for Q&A. So to start off, a very busy slide, but I hope you all appreciate everything that's on there. So in primary care, we often see patients once something's already tipped into being urgent. So those repeat contacts, crisis appointments, or escalation to GP time that might have been avoidable earlier on. So when we're talking about prevention here, we're really talking about spotting patterns sooner, whether that's frequent attenders, poorly controlled long-term conditions, or people repeatedly contacting the practice for the same issue. Catching those earlier gives practices more options. So signposting, supported self-management, a proactive outreach rather than firefighting on the day. So the context on this slide here won't be a surprise to anybody. Demand continues to rise, workforce capacity is tight, and many practices are still absorbing pressure at the front door, especially in the morning. And what we're seeing is that when everything funnels into the same day GP appointments, it creates stress for staff and frustration for patients. And nationally, this is exactly what current access and productivity priorities are trying to address, shifting the demand to the right part of the system earlier and more appropriately. So this isn't thinking about practices doing more on top of everything else. In fact, the intention is the opposite. So prevention works best when it's built into existing processes. So how patients are triaged, how messages are worded, and how teams respond consistently. So for example, identifying a cohort once and putting a repeatable approach around them is very different from dealing with the same patient 5 times reactively. It's about reducing repetition and escalation over time. And at practice level, this means clearer workflows, agreed responses, and trusted resources that the whole team can use, not just clinicians. And at PCN, ICB, and neighbourhood level, it's about doing this once and doing it well. So shared cohorts, shared assets, shared messaging, and learning what works across multiple practices. And this aligns closely with where the NHS contracts are heading, and more emphasis on prevention, population health management, and collaboration across practices rather than each one reinventing the wheel. It's really important to say this isn't about replacing GP or nurse input. Clinical care remains central, but we're talking about supporting patients before they reach the point where they need that level of intervention. So the current contracts increasingly recognise this. So whether that's through access requirements, the neighbourhood working, or prevention focused outcomes. And they're encouraging practices, PCNs and ICBs to use a wider set of tools to support their patients early in their journey. So this is what we're focusing on today. So prevention as a practical system-wide way of easing pressure, improving patient experience, and making better use of limited clinical time, not as an extra task, but as a smarter way of working. So we need to shift our mindset from reacting to problems once they've already escalated to being more intentional and data-led in how we identify patients earlier. So in day-to-day primary care, we usually only see that demand once it's landed. But many of those patterns are visible before they reach that point. And if we step back and look at the data differently, we can see a different view. So one example that we can talk through here is the Johns Hopkins ACG system, which many areas already use at PCN or ICB level. So ACG helps stratify populations based on complexity and predicted future needs. And that allows systems to identify patients who are at higher risk of future demand, not just those who are already heavy users of the services. But alongside those tools like ACG, practices are already sitting on really valuable information and often have other tools in place that can help identify those high impact cohorts too. So that includes long-term condition registers, frequent attender lists, repeat contact data, and patients with multiple unmet needs or poor control. And when we start bringing that information together, whether it's at practice, PCN, or neighbourhood level, we can see much more clearly where prevention is likely to have the biggest impact. And that's a very different approach to trying to do a bit of prevention for everyone, which is rarely realistic. So this way of working aligns closely with the current NHS priorities, like we said, around population health management and the neighbourhood working, and also looking at reducing that avoidable demand. And systems are increasingly being asked to demonstrate more proactive, preventative models of care. And this is one of the practical ways that we can start to do that using the data that we already have access to. So the other important shift here is moving beyond the idea that prevention should only focus on the very highest risk patients. So of course, those patients matter, but prevention is often most effective when we also look at activation potential. So who is most likely to benefit from support to self-manage before things deteriorate? This is asking slightly different questions of our data. So who is contacting us frequently, but doesn't necessarily need clinical intervention every time? Where do we see repeated demand that could be better supported through education, self-care, or that earlier intervention? And then are there any groups that are more likely to engage with preventative support if it's offered in the right way? So at scale, we see consistently that this works well for cohorts such as the ones here, so MSK pain, mental health, weight management, asthma and COPD, diabetes and ADHD services. So these are areas where patients often want support, but don't always need a GP appointment as the first step. So from a delivery point of view, this also works best when practices aren't doing this alone. So PCNs and neighbourhoods can define shared cohorts, agree common approaches, and use consistent messaging and resources which aligns with the direction of travel in access, prevention and productivity across current NHS contracts. So supporting those self-care and self-management at scale, we need to make self-care feel credible, structured and genuinely worth the effort in primary care. So most people working in general practice already believe in self-care and self-management in principle. The challenge isn't belief, it's time, it's trust and it's consistency. So when things are busy, it's hard to remember what to recommend, and staff don't always feel confident that what they're signposting to is reliable or appropriate. But good self-management support isn't about handing patients a leaflet and hoping for the best. It's working best when it's consistent, trusted and easy to access, both for patients and for staff. And that means everyone in the practice gives broadly the same advice, using the same resources, so patients aren't getting mixed messages depending on who they speak to. And this works best when prevention is built into those everyday workflows. So triage, messaging, reception handling, clinical templates. If self-care relies on individual memory or goodwill, it won't scale. But when it's built into those processes or the clinical systems, it becomes part of how the practice operates rather than an extra task. So in practical terms, this often means using standardized, quality assured resources that teams trust and offering support earlier in the patient journey before a problem escalates into those repeated contacts or urgent appointments. And that early intervention piece is where prevention will really start to pay off. And this matters because when patients understand their condition better and feel more confident in managing it themselves, we see fewer repeat contacts, fewer avoidable appointments, and better use of limited clinical time. And over time, that leads to calmer workflows for practices and a better experience for patients. So one thing that's really important to making that prevention work in practice is the proactive outreach and communication. So prevention doesn't work if patients only hear about their options at the point of crisis, when they're already worried, they're calling at 8 a.m. or they're chasing an appointment. So by then we've missed the opportunity to intervene earlier. But practices and PCNs that do this well are clear and intentional about how they communicate. So they use consistent, repeatable, templated messages to explain what support is available, when it's appropriate to use it, and what patients can do themselves first. So that might be through text messages, it might be through the NHS app or the practice website. It could be on your waiting room screens or posters. And it could be written in simple reception scripts. But the key is that the message is joined up across all of these touch points. And this isn't about pushing patients away from care. It's about setting expectations early, building that trust and helping those patients feel confident to manage issues sooner before they escalate into something more complex. And at its simplest, good prevention-focused communication is about the right message through the right channel at the right time. And when that's done well, patients are clearer about their options, demand is more evenly spread, and practices regain some headroom to focus on those who need clinical input most. So there are three things that are worth remembering. So make sure you match the channel to the message. So different needs require different routes. So that could be a different age, a different level of understanding. People use different channels to communicate. So think about who you're trying to get the message to. Small proactive changes can have a big impact on demand over time. So those repeatable messages, you get them out and you keep them on your social media, they can have a huge impact over time. And then clear communication, that supports prevention by reducing that uncertainty in repeat contact. So by having that information readily available to patients, it just makes it that journey much easier for them. So we also need to think about positioning digital support in the right way as part of a balanced prevention strategy. It's obviously not a silver bullet. Many people still don't use digital, but there's now strong evidence showing that patient-facing apps can support self-management, but only when they're used in the right context with the right patients. So they tend to be most effective in areas like mental health, MSK pain, weight management, and long-term conditions where ongoing support, education, and behaviour change really matter. But we're also seeing growing appetite for digital support, particularly in mental health. Many patients are actively looking for something that they can access immediately, especially when appointments aren't available or waiting lists are long. But that immediacy is a big part of why digital can support prevention rather than just shifting demand elsewhere. And where apps work best in practice is when they're used intentionally. So, for example, as an immediate option when no appointments are available, so no patients are left with nothing, or as an alternative or a complement to medication, or while patients are waiting for other services, rather than a replacement for any clinical care. But on the ground, this can look quite simple. Reception teams signposting patients to trusted, quality assured digital support, clinicians recommending or prescribing apps directly from within their normal workflow, and at a PCN level, running proactive campaigns to define cohorts of patients rather than relying on one-to-one conversations over time. And this is where Orca plays an important role, helping teams feel confident that their digital tools that they're recommending are safe, are effective and appropriate, which is often the biggest barrier to adoption. So I'm going to pass over to Tom now from Orca, who's going to take you through there.
Thank you very much, Claire, for that. So the question is, how do we do this in practice? When I speak to my colleagues and to other GP practices, everyone is bought into the idea that self-care and self-management is essential. We've got this massive gap in terms of patient demand and the capacity of general practice to deliver on this. So the more we can empower our patients to manage elements of their own care, the more we can shift the dial towards a preventative model of care and one that places less demand on general practice. And as Claire said, as part of that self-care strategy, digital has a really important part to play. It's easy to scale. There are a range of options. And out on the market at the moment, there are about 350,000 different digital products that can help with patients' health and self-management. So there's this fantastic resource out there, which alongside non-digital methods can start helping our patients to self-manage. The question then, if it's not, is this effective? Is it worth my time? Is in fact, how do we do it in practice? How do we do it when I've only got 10 or 15 minutes with the patient in a consultation? Where am I supposed to fit this in? And if we are signposting patients to self-care tools, how can we trust the tools we're referring them to? And how do we manage any liabilities? If I recommend an app to a patient and it's not suitable or the patient comes to harm, am I putting myself at risk professionally? And it's those kind of gaps that we've been working at Orca with a number of different ICBs to try and close. For those that aren't familiar with Orca, Orca stands for the Organisation for the Review of Care and Health Apps. We've been around for over a decade now and have worked with NHS England, the MHRA, NICE, NHS trusts across the country, general practices, social care departments, local authorities, and we've worked internationally as well with healthcare organisations. And what we're known for is for assuring and assessing the digital self-care market. So looking at all of the tools out there available for practices and creating an assessment that can be rapidly done, repeated every time a product updates, and easily translated into a metric or a kite mark so that clinicians, patients are very clear which products are safe for them to recommend and which ones are not. So the first thing what I'll do is I'll kind of describe a principle and then I'll kind of say Orca's approach to this, but you might take different approaches depending on where you work. But the first thing is to try and create a channel that patients can access independent of their practice. So if patients want to try self-care or they're open to it, have you got a route where they can find useful, validated tools to help them on that journey? We're in a great place in general practice in that we've been moved towards creating digital front doors that are highly functional. No more are websites just a promotional page for the practice, but now patients are getting used to booking appointments, ordering their prescriptions, all through our digital front door. And as patients become more used to accessing clinical services in that way, there's a great opportunity for them to be encouraged to try self-care options as a first port of call. Within Orca, what we've been doing is developing health app libraries, so libraries of digital self-care support, where everything within those libraries has been assessed, validated, and determined to be safe to use, and then working with practices to host those on their digital front door. So however your website or your digital point of entry looks, make sure you've got a repository of digital self-care tools patients can access. This means that you haven't got to wait for the patient to call up and block up phone lines in order to access the self-care that they want. The second channels, then if that's kind of a patient-led channel to trying to find self-care options, the next channel is how do we bake this into our natural workflows? Claire mentioned very clearly consistency is critical. If self-care is just seen as a kind of bolt-on that sits over there and isn't a core part of the way we operate as practices, it won't get done and patients won't be referred to that self-care resource consistently. So it's important to make sure that all members of your team are thinking self-care and directing patients to the same resources. One way this might work, and again, Claire alluded to this, is using your online library or repository of self-care tools. So giving your receptionists and your kind of scripts that they can use. So when there are no appointments, they know where to direct patients to in the meanwhile, while they're waiting for their appointment. Or making sure that your nursing staff and your clinical pharmacists, when they're doing their long-term condition reviews, do they know where to signpost their asthmatic patients to, their COPD patients, or their diabetic patients? There are a whole host of really effective evidence-based digital tools, many of which are now being recommended by NICE that can support with those long-term conditions. Perhaps your social prescribers can use self-care apps in order to support smoking cessation, alcohol reduction, or weight loss. And of course, we touched on mental health as well as being a great avenue where digital self-care can help. One of the things that Orca does in this space is we've actually built a formulary, a prescribing tool, if you like, for digital self-care that sits within eMedicine System 1. So with a touch of a button, your clinicians can open up a formulary like the BNF for medications, search for an appropriate digital tool, and send it straight to the patient by email or SMS. So it perfectly reflects the way we naturally manage consultations that involve a medication prescription. It's digital self-care tools we're recommending instead. And then the third route. The third route is looking at ways that don't add to workload or require any kind of clinician involvement at all. And that's driven by automation at scale. There are a number of different automating solutions out there that can identify, stratify cohorts and manage them based on a set of rules. And that gives us an opportunity to identify our at-risk cohorts, our high-impact cohorts, and proactively direct them towards self-care before they even need to pick up the phone and call the surgery. This model shows how we've developed this using the EMIS electronic health record system. We've been working with EMIS to create an automated workflow for health app recommending. So it will identify cohorts of patients where you can have the largest impact, such as, for instance, cardiovascular disease prevention, or perhaps you're seeing patients with asthma after their asthmatic review, and automatically send them some recommendations of digital self-care tools that can help them manage. Again, getting well ahead of the patient, even needing to call the surgery, but without a member of your team having to even lift a finger. This is the potential to be transformational when it comes to population health management, and is so well aligned to the principles of neighborhood health working and preventative care that I think it will be a powerful way to help patients self-manage more of their health. So I want to just work through a practical example of what this could look like in your practices. And let's take the example of mental health. So taking that first channel, the kind of patient-directed channel, so you've got this resource on your digital front door on your website with some validated self-care options patients can try. You might have a patient calls up the practice requesting an appointment for their mental health, and perhaps the next appointment's not for 3 or 4 weeks. At that point, your receptionist has the opportunity to say, would you be interested in trying some self-care for your mental health? And if the patient says yes, then with a very simple text message, email, or NHS app message, the receptionist can signpost the patient to that digital resource so the patient can start trying self-care. And in that way, you're potentially avoiding an appointment, or if the patient still wants to be seen in 3 to 4 weeks, you're getting them started on some of their treatment ahead of seeing the GP. Let's look at that second channel then, that clinically directed channel. Again, using the example of mental health, let's say a patient's consulting with one of your clinicians. They've talked about what's been going on, and the clinicians decided that usually they'd either refer or start medication, but the patient doesn't want to try medication for their depression, or perhaps they've tried it and they've not been able to tolerate the medication. But the next appointment with the mental health team is 6 to 9 months away. This isn't an uncommon scenario. And what often happens in these instances is the patient will end up coming back to the practice perhaps every month, every 6 weeks, until their care can be taken over by the mental health team. And that places a large demand on GP appointments. Well, here's an opportunity for the clinician to offer something different. They can say, would you be interested in trying some digital support for your mental health? And if the answer is yes, then the clinician can either signpost them to your website, your online repository, or if you're using Orca, even do a prescription there and then for a digital health app. So the patient can get started with accessing CBT or mindfulness therapy whilst they're waiting for their appointment. Again, reducing the demand on future appointments. And then the last channel, that automated channel. I want you to imagine you're working at a PCN or a neighborhood health center lens this time. And let's say a QI project is undertaken to identify your most frequent attenders, and depression is a key theme, a recurring theme amongst those frequent attenders. What you might then do is set up an automated workflow so that those patients that have a diagnosis of a mental health condition and are highly likely to become a frequent attender are proactively recommended self-care options to try and stabilize their condition and reduce the likelihood of them recurrently coming back to the practice for support with their mental health. Now, you might be thinking, okay, I bought into digital self-care. I can see that digital has a lot to offer here, but is there an evidence base behind it? Well, I could talk all day about various apps that I've assessed that have a incredible evidence base. There are COPD apps that can reduce your chance of an emergency attendance by 50%. There are diabetic apps that can lower your blood sugar equally or better than metformin, our first line drug. But fundamentally, here's some high level data that comes from Orca that shows the impact that can be had. You can see in the bottom left-hand corner, 90% of patients that downloaded apps found, 90% of patients that were recommended an app by their clinician went on to download it. And those apps had impacts on their weight management, their lifestyle behaviors, and their ability to meet their personal health goals. You can see in the top right-hand corner, working just with social prescribers, PCNs were able to reach 11% of their diabetic patients and get them using digital self-care tools within just a short period of time, with ambitions to increase that to 20% of the diabetic patients by the end of the year. And you can see a few other kind of case examples of how this has been used in PCNs and in practices to impact those high impact cohorts. We've got a little bit more information you can find about Orca. If you scan that QR code or you make a note of that URL, you'll be taken to a virtual showroom. You'll just need to enter in your name and your email address, and you'll see a web page open up that explains a little bit more about the solution, which we've called Orca Care Nav in primary care, as well as some demo videos and a little bit more detailed information on how you could apply this in your practice. But fundamentally, this is about how do we support patients to self-care and how do we do it in a way that's sustainable and doesn't feel like more work for general practice. It's just a smarter way of working. And digital, for me, is fundamental to that shift.
Thanks, Tom. That's great, and that's really interesting. All of the apps that can be used for all sorts of different things to support self-care and self-management. So looking at this, how do we turn everything that we've talked about today into something practical and usable in practice? So the key message is that prevention works best when it's structured and it's proactive. So it's not about doing everything for everyone or launching lots of new initiatives at once. It's about being intentional, using data to identify where effort will have the biggest impact and putting those simple, repeatable approaches around those cohorts. So again, using those clear communication and trusted resources, they really matter here. So when teams are confident in what they're offering and patients receive those consistent messages, prevention and self-management stop feeling like that add-on, like that bolt-on that Tom mentioned, and start to feel like part of normal care. And we've also seen that self-management can reduce demand, but only when it's done, again, intentionally. So this means supporting those patients earlier and giving them something meaningful that they can use and embed this into those everyday workflows rather than relying on individual enthusiasm. In terms of what practices can do next, the message is simple. It's start small, pick one or two cohorts where demand is high and the opportunity for prevention is clear. Agree a consistent approach as a team, test it and learn from it. So get that trust under the belt with one or two small projects first. And then once that consistency is in place, scaling becomes much easier, whether that's across a PCN, a neighbourhood or a wider system. It's that combination of focus first, then scale, and that makes the prevention sustainable rather than overwhelming. And what we're describing here aligns with where systems are being asked to demonstrate progress, so that population health management, neighbourhood delivery, reduction in avoidable demand, and better use of non-clinical interventions. So I just wanted to talk briefly about what we can add alongside Orca's CareNav capability. So CareNav itself is a navigation solution with that library, and that's really useful to have in your back pocket as a receptionist or a clinician. And what we focus on here at Redmore Health is helping practices to make it work in the reality of day-to-day general practice. So that usually starts with stepping back and looking at the current versus future workflows, Many teams are running existing care navigation processes, but they may be on a spreadsheet, they may be in a different system, they may be difficult for staff to use within that short space of time that they have with a patient. And we can help practices to identify where some of these steps can be removed, can be simplified, or they can be joined up. And a big part of this is linking things like CareNav into those existing workflows and communicating this change to patients. And that way patients get clearer information about what's happening with their request, what's happening with the apps that they're being given, are they safe? All of those questions that Tom went through. So practices have much clearer processes in place and can communicate those to the patients. And then we support the practices with those patient communications. So for some practices, that includes the social media managed service, and that can be used to explain the navigation process in plain language. So patients know what to expect before they contact the practice, and they could even download an app from a social media post that suggests one of these trusted apps. But that early understanding of what may be offered to them can reduce confusion and the follow-up queries. And then at the PCN and ICB level, again, the focus shifts to scale and consistency. So rather than every practice solving the same problems in isolation, this is about sharing what's working well, using common templates, common tools, and supporting a more joined up approach across a whole area. So we also support systems to understand the impact of these changes, particularly in terms of admin time saved or those appointments that are being saved from the frequent attenders. And that helps move the conversation away from sort of anecdote towards something that can be evidenced and built on over time. So all of this is supported through the Digital and Transformation Hub, which provides a structured way to learn with resources and support. But if you'd like to find out more about the ways that we can support you, please get in touch. My email is on the screen there and I'll share it in the chat as well. Thank you so much for joining us today. I hope you found the session useful. And like I said, if there's questions that you have, please get in touch. Thanks very much to Tom. That was a really good session. And we'll pop all of these resources in the D&T network, but we'll send you an email with the link in there for you. So thank you very much for joining today.